Hello everyone, welcome to Medicine with Faizan. So this ECG quiz is obviously a little difficult and reasonably so there was a mixed response. Some were calling it VT, others were calling it SVT with aberrant conduction. So what it really is? First of all, I must emphasize that even the expert cardiologist can get confused while confirming whether it is VT or SVT with aberrancy. So write it somewhere down that whenever you cannot make a decision about it, simply treat it as VT. This is my golden point from this video today. Now coming back to this ECG tracing. Always remember that whenever you come across a broad QRS complex tachycardia as in this ECG, you have three differentials. Either it is SVT with aberrancy, or it is VT, or it is AFib with WPW syndrome. The last one, AFib with WPW syndrome, has a distinct morphology. The rhythm is usually irregular and there are sometimes delta waves visible. The QRS complexes have a peculiar morphology from which you can easily tell this is WPW. We'll show you the ECG in different quiz. For now, let's come back to VT versus SVT. There are some features which, if present, suggest that we are dealing with VT instead of SVT with aberrancy, and these are listed here. First of all, there will be a history of myocardial infarction or ischemic heart disease. If such history is present, think of VT. There would be AV dissociation, meaning no relationship between P waves and QRS complexes, and the number of QRS will be greater than the number of P waves. Now, to learn the difference between complete heart block and AV dissociation, you can join my ECG masterclass. Another feature is there will be capture beats, which are, for the sake of simplicity, normal QRS complexes in between broad QRS complexes. There can be fusion beats where the QRS has a morphology in between the capture beat and the QRS, broad QRS tachycardia. Northwest axis, meaning positive QRS in lead AVR and negative QRS complexes in limb leads, is also suggestive of VT. Concordance or discordance in all chest leads, meaning the QRS complexes in all the chest leads from V1 to V6 is either positive or negative. And if that feature is present, think of VT. Josephson sign in V1, which is a notching at the peak of S wave. If it is present, there is a higher likelihood that we are dealing with VT instead of SVT. And finally, Brugada sign, meaning the duration from the onset of R wave to the peak of S wave is 2.5 small boxes or 0.1 second. Now, of course, not all of these features need to be present, but the more these features are present, the higher the likelihood that we are dealing with VT. In this ECG, as you can see, the QRS is positive in lead AVR and negative in most of the limb leads. So northwest axis is present. Look at this beat here and compare it with other beats. It seems to have a morphology different from other beats. And this same feature is present in other leads like lead AVS, lead AVL, and lead AVR. So maybe it's a fusion beat. Now look at this morphology and compare it with this one. Do they look similar? Clearly no. Again, look at all these beats and now look at this one. There is peaking of P wave here, which is not present in other beats. So maybe P wave is superimposed on T wave here. So you see P wave is present in some beats while absent in other. There is no relationship between P's and Q's, and since the number of QRS complexes is more than the P waves, this is AV dissociation. So these are the features which are present in this ECG, and there is a high likelihood that we are dealing with monomorphic ventricular tachycardia and not SVT with aberrancy. I hope you enjoyed watching this explanation. For more such videos, subscribe to my YouTube channel. Thank you.